ITP can be very challenging for a number of reasons. I think making the diagnosis is challenging sometimes because we don't have one test that can tell us that a patient reliably has ITP, so it really is a clinical diagnosis. So sometimes the diagnosis itself can be challenging. I think the highly refractory patients are a challenging cohort of patients. We do have expanding therapeutic options, but when patients are not responding, they cycle through many lines of therapy. That is always a challenge. And of course, we always use our best drugs up front. So if patients do relapse and fail therapies, then we're looking at the drugs that have more side effects and probably more immunosuppression in order to treat the highly refractory patient. So they can be challenging. The third kind of challenging patient are the patients that have ITP and thrombocytopenia and either active bleeding or a strong risk of bleeding, but then also have a blood clot. Those are the patients that keep us up in the middle of the night because, there's this balance between bleeding and clotting. And you want to prevent thrombosis, which can be fatal, but then also you want to prevent the risk of bleeding. And so the TPO receptor agonists do predispose patients to DVT and VTE. Fostamatinib does not seem to have that same association. There was also an ASH abstract presented in 2019 talking about the risk of thrombosis. Among the clinical trials in which Tavalisse was tested, there does not seem to be a high rate of thrombosis in the FIT experience. And so it is wonderful now to have treatment options that do not increase the risk of thrombosis for those kind of patients that are at risk of VTE.